Good evening to all of you. I welcome you this evening to an interesting topic on behalf of Special Interest Group Reproductive Endocrinology, Indian Fertility Society. This evening, we have two interesting topics, and as fertility clinicians, we need to know a lot about how hormones affect our fertility outcomes. And we have Dr. Abha Majumdar as an expert to give us inputs. And we are happy that our convener, Dr. Puneet Arora, is also part of the program. She's currently a little busy. She will join us shortly. It is such a pleasure welcoming Dr. Abha Majumdar. She is the consultant and director of the IVF Center at Sri Gangaram Hospital, New Delhi. She has many credentials, won multiple gold medals, and anyone who has listened to her talks will be enamored as to how she can just give the perfect content in appropriate words. She's received the Lifetime Achievement Award, IVF Champion Year 2019. She's the course director of the Fellowship in Reproductive Medicine, and it must be a pleasure to be her student. And world over, and in Indian Fertility Society, she has a mark as an academic person par excellence. Welcome, Abha ma'am, to be with us this evening, to take your precious time off to share your pearls of wisdom. And I would also be happy if you could share Dr. Puneet's slides, Karan. Puneet is a great friend and the convener of the SIG Reproductive Endocrinology, a very soft spoken person, and she's less words and more in action. She's the director, Center of Infertility and Assisted Reproduction at Gurgaon. And she's been the executive member of Indian Fertility Society, founder member of Fertility Preservation Society of India, and currently she's been guiding IFS SIG Reproductive Endocrinology with the post of convener. And she will be joining us shortly. She's currently having an emergency. With this, we go over to the program proper of today. I welcome Dr. Anjali Satya. She has done her MBBS at Trivandrum Medical College, her MD General Medicine at MMC, Madras Medical College, and she has done her reproductive endocrinology, the DM endocrinology at CMC Vellore. And currently she's a consultant endocrinologist at Vijaya Group of Hospitals and at Apollo Group of Hospitals. Can I request you to share Dr. Anjali Satya's CV, please, Karan? And Dr. Satya will be speaking to us about how prolactin has a role in affecting the other fertility hormones. She's another person, any topic you give, with absolute commitment, the topic would deliver the content. And I request Dr. Abha also to pitch in as Anjali is trying to share her slides on the topic of prolactin and its interplay with other fertility hormones. And I would request Dr. Abha Majumdar to chair this as the expert on this evening's program. Dr. Anjali, you can start sharing your slides, and Abha ma'am, you can start off with your comments on the beginning of the topic.
I think reproductive endocrinology is a very important part of all fertility specialists, and we all need to be aware when not to treat. It is very easy to say that you can give any drug for any elevated hormone, but to know when to treat a high prolactin level and when to leave it as such is more important. I'm sure today we will be enlightened by this aspect of hyperprolactinemia also while we hear Dr. Anjali speaking.
It's actually, we always, as gynecologists, as reproductive clinicians, we talk a lot about hormones. But when we have the perfect expert, that is an endocrinologist, pitching in with us, it'll be a great learning experience. With this, I request Dr. Anjali Satya to start her presentation.
Thank you very much, ma'am. It's my honor and privilege to be here, and I thank the IFS Society to have given me this opportunity. So the topic assigned to me is on effect of prolactin on subfertility. So the agenda of my presentation would be to go through the history, structure, physiology of prolactin, the regulation of prolactin secretion, reactivity, especially immunoreactivity issues, problems with prolactin assay, effect of hyperprolactinemia on reproductive function, and some case scenarios if the time permits. So prolactin is a hormone which we all associated with lactation. And this was first discovered more than 90 years ago based on the ability of pituitary extracts to stimulate lactation in rabbit. Riddle et al. In 1933 had described it. Later on, it was documented in bovine milk. And in human beings, prolactin was identified and measured in the 1970s. If you look at the evolutionary history, right from chordates, the prolactin genes have been existing, and they have gone through a period of evolution to the current existing mammals. So prolactin is a polypeptide hormone, and it is secreted by lactotrophs, which represent about roughly 20% of the anterior pituitary. As is seen in the picture, the prolactin is located on the postrobasal part of the anterior pituitary. They are acidophilic cells, and they belong to the transcription factor, namely the PIT1 dependent lineage, which is also responsible for secretion of somatotroph, that is the growth hormone, and also the thyrotroph. So it's the PIT1 transcription factor, which is actually responsible for secretion of prolactin from the lactotrophs. And in PIT1 deficiency or mutations, it is usually characterized by multiple pituitary hormone deficiencies in a neonate. So it is synthesized as a pre-hormone, and it is cleaved into a 199 amino acid peptide, which is the active prolactin. The monomer prolactin is the bioactive hormone, but it can also exist in circulation as polymers, bimers, tetramers, because it can combine with itself, or it can form huge complexes with immunoglobulin molecules. And that's when we term it as macroprolactin, which is also immunogenic. So these larger prolactin molecules, which are not bioactive or which do not have physiologic function, are estimated by our current immunoassays. So this is very important to know, that it is only the monomeric prolactin which has biologic action. So this is one of the anterior pituitary hormones, which is not under a releasing hormone. Rather, the regulation of prolactin secretion is under inhibitory control of dopamine. And dopamine exerts a negative influence on the prolactin secretion. There are certain other factors like GABA-aminobutyric acid, the somatostatin, and calcitonin, which can exert negative effects. And stimulatory factors include the TRH, which is elevated in patients with primary hypothyroidism. That explains the high prolactin in people with primary hypothyroidism. The TRH is a stimulatory factor. Vasoactive intestinal peptide, the vasopressin, angiotensin 2, neuropeptide Y, substance P. These are other factors which have positive actions on prolactin secretion. But prolactin secretion is predominantly under the negative influence of dopamine. So any factor that suppresses dopamine elevates prolactin. So if you look at the dopaminergic regulation, the effect starts within seconds. It is a well-known fact clinically that when we, especially drug-induced hyperprolactinemia, a single tablet of metoclopramide or domperidone can elevate prolactin within 12 hours to more than 100 or 150 above. So the action can be seen within seconds, where the dopamine activates the potassium channels, leading to membrane depolarization, suppressing the voltage-gated calcium channels, and hence the calcium entry reduces, and that leads to reduction of prolactin release. The action sustains over minutes to hours, and the dopamine then suppresses the adenyl cyclase activity, further leading to suppression of the prolactin gene expression. And if the effect persists, the inhibitory effect can persist for days together, where it inhibits the lactotroph proliferation and decreases the size of the lactotroph cells in the pituitary gland. Now, prolactin is a very interesting hormone. It's very labile. The levels are not stable. It has a negative feedback loop, as is seen with all other endocrine hormones, where they have a negative feedback loop onto the pituitary and the hypothalamus. Paracrine actions are well documented with prolactin, and prolactin is known to have a short feedback loop within the cell itself. So it controls its own secretion through a short loop, stimulating the dopaminergic neurons in the hypothalamus and it's within the own lactotroph cells by a small autocrine loop. So short loops and long loops all exist in prolactin secretion. Prolactin has important paracrine function, and it also has actions on sites other than breasts, which I will come to later. So this is the distribution of the prolactin receptor. So it is not only seen in the pituitary gland, but it is also seen in other parts of the brain, the heart, the lung, the thymus, the spleen, the liver, pancreas, kidney, and most importantly, the topic of interest today, the uterus, the endometrium, the granulosa cells, especially the luteinized granulosa cells, the skeletal muscle, and the skin. So it's very, very widespread, and that can explain its pleiotropic effects on other systems. So looking at the prolactin receptor and its ubiquitous expression, it has multiple other action which we term as pleiotropic effects. So the most important action is on a mammary gland, where during pregnancy, it leads to ductal side branching, alveolar budding, and it sustains lactation. And the stimulus there is essentially a nipple or suckling reflex. It also has effect on pancreatic beta cells, where it increases the beta cell mass, replication, and improves the glucose-mediated insulin secretion. Probable role may be there in gestational diabetes or postprandial hyperinsulinemia. It also has a very important role in adipocytes, especially the brown adipose tissue differentiation for thermoregulation. It's also seen, it has an important role in breast gland development, especially breast hypertrophy during pregnancy. And this action is mediated through its regulation of fat stores. It has an important immunoregulation action through which we can explain some of the effects that prolactin has on implantation failure and especially effects on the endometrium. So it is responsible for T cell activation and proliferation, expression of co-stimulatory molecules on antigen-presenting cells, and probable role may be seen in multiple sclerosis in SLE. So what is the fate of prolactin molecule in the circulation? It can undergo polymerization, as I mentioned, with other prolactin molecules, or it can form large complexes with immunoglobulin, forming bioinactive complexes, or prolactin being a peptide hormone can undergo proteolytic cleavage and gets eliminated from the circulation, or it can undergo glycosylation or phosphorylation, both of which are inactive forms of prolactin, and they get eliminated very fast from the circulation. If you look at the circadian rhythm, prolactin also follows a circadian rhythm, and we have a biological clock that is a suprachiasmatic nucleus in the hypothalamus, which determines the circadian rhythm of most of the hormones in our body. And prolactin also has a circadian rhythm. And the peak secretory pulses, usually it is secreted in pulsatile fashion, and we see about 13 to 14 pulses in a day, 24 hours time. And maximum secretion is seen roughly between 3 to 6 a.m., deep sleep and early hours of the morning, both in men and women. And the levels are seen more in women compared to men. A small peak is also seen in late afternoon between 2 to 6 p.m. So when do we collect the sample for patients when we ask for prolactin? Now, most of us face this problem. Some of the patients are referred for very borderline elevation of prolactin. And when we ask them, the sample collection would have been done at home. The person for collection would have come at 6 a.m. They would have just got it from sleep and given the sample. The requirement is because high prolactin pulses are seen deep sleep and early hours of morning, it stabilizes roughly about 3 to 4 hours after a wake time. So it's better that the patient gives the sample at least after 1 or 2 hours of wake time. They should not just get up from sleep and give the sample. You see the graph here, the stabilization of the values are seen beyond 180 minutes, and then it stays stable. So this is a time when you must estimate the prolactin rather than check it when a patient just wakes up from sleep. Does prolactin vary between phases of menstrual cycle? Yes, but the variation is very minimal. The follicular phase prolactin levels are smaller. If you see the red line here, the levels are seen, and a slight surge is seen, which is seen close to the LH surge in ovulation and in the early luteal phase. You may see a mild elevation of prolactin at that time. And if you look at a pregnant woman, the prolactin level progressively increases across the period of gestation as it advances. Causes of hyperprolactinemia, always we should remember the physiological cause. If a young woman walks into your office with amenorrhea and hyperprolactin, rule out pregnancy. That's the first thing. And then we always think of this as a checklist we have. And the most common clinical cause of hyperprolactinemia is a drug history. So it's very important to take a good drug history. So physiological causes would be pregnancy, even stress, sleep, patients who have had chest trauma, any surgeries, or they can have, a prolactin elevation. Or if we look at seizure disorder, even if a recent seizure, sexual intercourse, all this can lead to prolactin elevation. The pathological causes, drug history, I would come to it later in the slides. You have to take a good detailed history of whether patients are on any prokinetic drugs, like, most of the patients are on PPIs for acidity, reflux. Many patients may be on antidepressants, SSRIs, antipsychotic. Even estrogen-containing pills, patients who are on OC pills for a long time may have moderate elevation in prolactin. Abnormal causes would be cellular masses, could be a prolactin secreting tumor, non-functioning adenoma, hypophysitis, any condition which affects the stalk, even empty cella, infiltrated disease of the hypothalamus or pituitary gland can cause hyperprolactinemia. Other common medical conditions which can lead to hyperprolactin, the first thing we should always do as a checklist is rule out primary hypothyroidism in most of these people. Sometimes it may be just a simple case of primary hypothyroidism leading to a secondary hyperprolactinemia because of elevation of the TRH levels. Patients with renal failure, adrenal insufficiency, PCOS, about 20% of women may have hyperprolactinemia. You may also encounter macroprolactin in some of these patients, especially when you see a woman with regular cycles, high prolactin, unexplained, no galactorrhea, MRI cella is normal. We should always think of ruling out macroprolactin, which does not require any treatment. So when do we test patients? Women with galactorrhea, oligoamenorrhea, infertility, menstrual disturbance, they complain of sexual dysfunction. Hirsutism, which is again one of the manifestations of hyperprolactinemia, or hypoestrogenic state. Patients may complain of vaginal dryness and dyspareunia. Men do not come early, they usually come late because most of them do not report erectile dysfunction. They may have decreased libido, sometimes even galactorrhea in men has been described, gynecomastia has been described, and or otherwise they come very late with evidence of mass effect, large cellular tumors causing visual disturbance. Children may have delayed puberty, signs and symptoms of mass effect, or girls may come with primary amenorrhea and galactorrhea. And large cellular masses usually cause visual disturbance or headaches. Now, there are problems with prolactin assay. The commonest assay that we use is a chemiluminescent assay. It is now recommended that we should always look for macroprolactin, especially when you do not see much biological effects of the high prolactin in your patient. So somebody who walks in with a little high prolactin, regular cycles, no effects of high prolactin, and you would want to know whether this patient actually has a macroprolactin, do what is called as a PEG precipitation test, where polyethylene glycol is added to the sample and that macroprolactin is extracted, and we get monomeric prolactin as a separate assay component and macroprolactin as a separate. So if the sample is positive for macroprolactin, we do not treat these patients. The other thing which we should be aware of is the high dose hook effect. This is very common with glycoprotein hormone estimation. So the picture here shows a solid phase capture antibody, and this red part is called the signal antibody. So normally, if a person has prolactin in the circulation, which is the analyte, this gets bound to both the solid phase as well as the signal phase. So the prolactin molecule gets sandwiched between the solid phase antibody, the capture antibody, and the signal antibody. And this is released as one signal. But what if a person has a large amount of prolactin molecules in the circulation? So suppose a person has a macroprolactinoma and prolactin is more than 1000 or nanogram per ml. The prolactin itself will bind all the sites of the signal antibody. It will not allow the signal antibody to come and bind the solid phase antibody. And when you wash up the supernatant, all these molecules which are binding the signal antibody gets washed off and you get a low value of prolactin. So somebody who has a macroprolactinoma, you are suspecting a tumor, but you get a very low value, it's always better to get the test done in dilution. A similar high dose of effect is also seen for TSH and sometimes even with FSH and LH. But generally with the current assays available, we do not encounter these issues. So the normal prolactin levels, I think it's for the knowledge of the postgraduates if they are here. For a male, it's between 0 to 20 nanogram per ml. For an adult female is between 5 to 25 nanogram per ml. I wouldn't call it 0 because 0 is definitely low. So 5 to 25 would be normal. And for a pregnant woman, it may vary as much as up to 400. So after conception, the prolactin starts increasing exponentially as the gestation advances. Remember the units. So sometimes patients come from abroad, especially, we find that the laboratory units are different and there the range is different. The values may be in nanomole per liter and all that. So always look at the units before we infer them. Otherwise, you should not think that value is a high value and start investigating them unnecessarily. So check the units in which it has been estimated. Most of our labs here estimate it in nanogram per ml. So now coming to the topic that we have been with, how does prolactin affect fertility? Now, hyperprolactinemia, that is elevation in bioactive high prolactin, causes secondary hypogonadism, to put in a nutshell. So how does it do that? It suppresses the GnRH neurons. How does it suppress the GnRH neurons? It is through Kiss-peptin or Kiss1 neurons. This is a metastasis suppressor neuron. And this neuron that you see here expresses a prolactin receptor on its surface. So the high prolactin comes and binds the prolactin receptor on the Kiss neuron surface. And Kiss-peptin is released. And this Kiss-peptin suppresses the GnRH neurons, subsequently leading to suppression of the LH-FSH, leading to secondary hypogonadism in both men and women. So in women, it is well known, the FSH-LH comes down, the woman becomes, either she starts developing oligomenorrhea or she develops secondary amenorrhea. She may also present with galactorrhea. In men, again, LH levels come down, the testosterone levels come down. So men suffer mainly from testosterone deficiency symptoms like erectile dysfunction, poor libido, and FSH-mediated action on the Sertoli cells also comes down, and the inhibin B levels also drop. So in male fertility, high prolactin, it inversely correlates with the sperm concentration. And if you look at the histopathology, it has led to varying degrees of impairment of spermatogenesis depending on the duration of hyperprolactinemia, ranging from reduced spermatogenesis to almost like complete absence of germ cells, especially in long-standing cellular masses. And usually men with prolactinomas present much later compared to women because women present earlier with amenorrhea, galactorrhea syndrome. Elevated prolactin, again, is associated with erectile dysfunction in men. Detailed studies on semen quality, including motility studies, are actually not very much there in the literature. And when we look at the therapy, bromocriptine versus cabergoline, improvement in seminal fluid parameters were more evident and rapid in patients treated with cabergoline. Many of these patients show improvement, almost like if the studies, most of these studies are in smaller numbers, and they have found that almost 60% normalize their testosterone levels. But for spermatogenesis to resume, most of these men would actually require gonadotropins. So we always give them HCG when they present with hypogonadism to improve spermatogenesis. When coming to fertility in hyperprolactin women, it causes amenorrhea and galactorrhea and ovulation because it suppresses and decreases the GnRH production. But is this the only action? Probably no. High prolactin has multiple other effects on the woman. It can cause granular cell dysfunction. It can cause inhibition of corpus luteal function, shortens the luteal phase. In fact, the luteal phase defect precedes the overt symptoms of hyperprolactinemia in women. So shortening of luteal phase probably may be a very subclinical manifestation of a mild hyperprolactinemia. It can affect the endometrium, especially endometrial receptivity, and it decreases implantation. by causing desynchronization between the blastocyst and the endometrial receptivity. So high prolactin, how does it affect the granulosa cell? It's usually through FSH. So it inhibits the FSH mediated estradiol secretion in the pre-ovulatory follicles due to reduction in aromatase activity. So it is the reduction in aromatase activity which leads to fall in estradiol in the pre-ovulatory follicles, whereas some other enzymes are amplified. The actions are not very well described. Prolactin receptors have been documented only in luteinized granulosa cell, but not in the small pre-follicles. So probably prolactin may play a role in the mature follicle during the time of ovulation. High prolactin in women who have regular cycles, so-called ovulatory cycles, may actually lead to luteal phase defect, as I mentioned earlier, and low progesterone levels. An immune dysregulation induced by hyperlactin, which I mentioned in the earlier slides, may alter the implantation rates and affect pregnancy outcomes. Other roles in female fertility, it may affect oocyte maturation and fertilizability. Now, prolactin has been documented in the follicular fluid of these patients. And whether this prolactin, which is seen in follicular fluid, has a positive role to play, it's something which more studies are required. It also is responsible for early corpus luteal formation and survival. It may cause improvement of blastocyst implantation potential. It leads to synchronization of the podocyte development in the endometrium and the blastocyst synchronization. For low motile sperms, it may act as a pro-survival factor, and it may has a very important role in decidualization of the endometrium. So when you look at all these factors, probably the endometrial receptivity, the implantation window, all these are probably have been regulated well by the so-called prolactin within the local environment. So when you look at the relationship between prolactin levels and ART outcomes, prolactin levels are definitely higher in stimulated than normal cycle, because in stimulated cycle, you're going to use gonadotrophins, and there's going to be high estrogen levels and hence a little high prolactin levels too. So moderately high prolactin levels have been found at the time of ovum pickup, before and after HCG administration in the luteal phase. But this is very transient. It's a well-known fact that in most of these women who undergo controlled ovarian stimulation, you may have mild prolactin elevation at all these points. There are so many theories. It's maybe because of the gonadotropin used, which can increase the estradiol level and hence the high prolactin. Also, it could be the stress of surgery which the women undergo. And women are generally distressed, especially if it's not the first attempt, it is multiple attempts. So we do not know what actually plays a role, but whether this mild hyperprolactinemia needs treatment or not, we don't have strong data to support and give recommendations there. So what they have found is, these are observations where women have undergone GnRH agonist long protocol and HMG together. They were found to have higher prolactin levels when compared to those women who were treated with shock protocol. And this positively correlated with the estradiol levels. And transient hyperprolactinemia during control ovarian stimulation also did not impact the peak estradiol levels reached, the number of follicles seen, the number of eggs retrieved, or the pregnancy rates. So treating this transient hyperprolactinemia, which is seen at these various points in time within a IVF cycle, whether it leads to any good outcome, it's questionable. Because some studies have said it is beneficial, some studies have said it is not. So we don't have an agreement there. There have been some prediction models for estimating a woman's fecundity before she undergoes an IVF cycle. And high prolactin has been there, included in one of these models, to say that a woman who have moderately high prolactin undergoing IVF cycle, probably it may lead to more negative outcome. But we don't have a recommendation to say that every high prolactin should be treated, or the transient hyperprolactinemia, which is seen in this, should be treated. In ICSI cycles, transient hyperprolactinemia before ovum pickup was associated with higher quality embryos, but no association was seen with clinical pregnancy rates. Also, in women who undergo OHSS because of multiple stimulation and high estradiol levels, high prolactin levels have been documented, but whether there's a cause and effect relationship, we do not know. We know that cabergoline is offered to these women for a different reason, that is for suppression of VEGF rather than prolactin suppression. So these are things which are seen in observational studies, but we don't have strong recommendations to treat transient hyperprolactinemia during IVF or controlled ovarian stimulation. So if I have time, can I go through 2-3 case scenarios? Okay, so case 1 is about a 30-year-old male who comes with severe headaches, and he was on analgesics, married for 1 year, had erectile dysfunction, but did not seek help for the same. He has been experiencing weight gain, severe fatigue, and felt very less energetic. And he was, because of his severe headaches, he was asked to do imaging, and MRI brain revealed a cellular mass. So he was obese, BMI was high, he had reduced facial hair, body hair, there was no gynecomastia. Examination of the external genitalia showed a normal testicular volume and normal consistency, and there were no evident abnormalities in the epididymis or vas deferens. The labs showed anemia. His free T4 levels were low, TSH was normal. Whenever we get T3, T4 low and TSH normal, we always think, okay, could this person have central hypothyroidism? His cortisol levels were 4. Normal is between 7 to 12. That was also low. And you look at his prolactin, which was about 200. And in dilution, we found a value of more than 3,000. His testosterone level was suppressed to 1.8, and FSH, LH were also low. Semen analysis revealed azoospermia. So this was a very clear-cut case of a cellular mass with panhypopituitarism, a macroprolactinoma, which was documented by the MRI. So this was a huge cellular mass, more than 2.5 centimeters, with both supracellular and paracellular extension. Fortunately, we have medical therapy to offer these patients, and he was put on cabergoline, 0.5 milligram twice a week. So whenever an individual comes with prolactinoma, whether it's a micro or a macroprolactinoma, we always, as endocrinologists, think of a condition called as multiple endocrine neoplasia syndromes, where prolactinoma is one of the conditions, and it can be associated with other endocrine organs. So we always check a serum calcium in these patients, especially young onset hyperprolactinemia. We think whether they may have associated hyperparathyroidism, and we call it as MEN syndrome 1. So this patient had no such features. He was started on cabergoline. 4 weeks later, his prolactin came crashing from 3,000 to 65. After 6 months, there was not much regression in tumor size, and he had to undergo transsphenoidal excision of the cellular mass. He was started on full hormone replacement therapy with thyroxine, hydrocortisone, and he was also put on additional injection HCG 5,000 units twice a week for the first 3 months. And he received HMG after that, and his semen analysis repeated 3 months later after adding FSH gave good results, and his wife conceived after that. Case number 2 is a 27-year-old married man, again for 1.5 years, came to fertility clinic along with his wife. He reported erectile dysfunction. This had affected their marital relationship. He had occasional headaches. He had gained more than 10 kilos in the last 2 years, sedentary lifestyle, again obese. He had strong family history of autoimmune thyroid disease. On laboratory examination testing, we found he was anemic. Hemoglobin was low, MCV was high, indicating large erythrocytes. Fasting blood sugars were borderline, and cholesterols were high. TSH was found to be more than 150, and free T4 was low. Prolactin was moderately elevated at 65 nanogram per ml, and he got his MRI done because he had headaches, and the MRI revealed this. So he had severe primary hypothyroidism with a cellular mass, and this mass is not a tumor, but we call it as a pituitary pseudotumor. And this happens because in primary hypothyroidism, the TSH goes up, the TRH goes up, and it is only the thyrotrope hyperplasia which shows as a pituitary mass, but actually it's not a tumor. And as we treat these patients with thyroxine, the cellular mass regresses in size. So always remember, whenever we treat any patient with hyperprolactinemia, always look at their thyroid functions as well. So diagnosis was primary hypothyroidism. Prolactin was moderately elevated. Even this corrects on its own by treating with thyroxine. Case 3 is a 36-year-old lady who was referred from a fertility clinic for elevated prolactin, 110. This was her 4th attempt at IVF. She has had regular cycles last year, and her hormone profile was then normal. So last year, prolactin was normal. All her hormone profiles were okay. Now she was amenorrheic for 3 months, and she experienced galactorrhea. She appeared distressed, stressed about the whole thing. She had consulted a psychiatrist and she was on sertraline and lonazepam for sleep. She was also on lesuride for her GERD symptoms that had worsened of late. So this was purely a case of a drug-induced hyperprolactinemia, and all we need to do is stop the drug and the prolactin normalizes on its own within 2 weeks' time. Medications that commonly cause elevated prolactin are antipsychotics, like the typical antipsychotics which we use in psychiatry for schizophrenia. Atypical antipsychotics can also cause high prolactin, like quetiapine, olanzapine, risperidone. Antidepressants, which many people take, SSRIs, fluoxetine, paroxetine, escitalopram, all these can cause high prolactin. Some antihypertensive drugs can cause, anticonvulsants can cause, prokinetic agents, which is heavily prescribed in our medical practice, also can cause high prolactin. Estrogens, cimetidine, ranitidine, opiates, all these can cause high prolactin. The last case that I'm presenting is a 27-year-old lady married for 1 year. She came for a general checkup as the couple were planning to have a baby. She reported regular cycles. Her labs showed normal thyroid function, but an elevated prolactin of 58 nanogram per ml. Her repeat sample showed a prolactin level of 64 nanogram per ml. She was worried. Her local physician had asked for an MRI, which was also normal. This lady who had regular cycles, macroprolactin was asked for and it was found to be present. The monomeric prolactin was found to be only 20 nanogram. Out of the 64, only 20 was monomeric, and she was reassured and sent back. So the key messages that I want to convey is that in any patient who comes with hyperprolactinemia, rule out physiological cause for hyperprolactinemia, especially pregnancy in a young woman with amenorrhea and galactorrhea or hyperprolactin. A detailed drug history is a must. Not all hyperprolactinemia need therapeutic intervention. Thyroid function must be tested in all. Treatment is essential when there is clinical evidence of secondary hypogonadism, both in men and women. In asymptomatic patients, consider macroprolactin. And now in our guidelines, it is mentioned that we should actually estimate macroprolactin for all patients who come to us with asymptomatic hyperprolactinemia. Estimate prolactin dilutions when you expect high values. Dopamine agonists are effective in treatment in lowering prolactin levels, eliminating galactorrhea, restoring gonadal function, and decreasing tumor size. But when we come to treatment of hypogonadism, men and women, if they are, they become hypoestrogenic, we need to supply estrogen to them, estrogen and progesterone combination. And in men, we give them HCG therapy to induce spermatogenesis. If you look at other endocrine conditions, 25% of patients with acromegaly and 10% of those with Cushing's disease may also have high prolactin. And here, as I mentioned, in women, estrogen and OCPs may be required in addition to cabergoline to treat hypogonadism. As regards prolactin and ART, functional hyperprolactinemia causes secondary hypogonadism. Higher levels of prolactin in follicular loop fluid have been found to be associated with increased oocyte competence. Prolactin, which is seen elevated in most of these cycles in a transient manner, may contribute to corpus luteal formation and survival. It may have a role in endometrial receptivity, improves blastocyst implantation potential, and probably survival of low motile sperms. But we do not have evidence to suggest treating these transient hyperprolactinemias, which is common in IVF, because it does not influence the outcomes in most of the studies. Though a limited number of studies have shown that high prolactin levels during IVF may be associated with higher implantations and pregnancy rates and better cumulative pregnancy outcomes, so don't treat. So this is again a continuation of what I mentioned earlier. The benefits of treatment of hyperprolactinemia preceding IVF, the data is scarce and divergent. So if somebody comes with going for an IVF or a control ovarian hyperstimulation, comes with mildly elevated prolactin, probably we don't have enough evidence to treat these mild hyperprolactinemic patients before IVF. And during IVF, again, we do not have strong evidence to suggest treating transient hyperprolactinemia, as I mentioned earlier. With that, I conclude my talk. And if there are any things that I need to discuss, probably I'm happy to. Thank you.
Abha, ma'am?
Yeah, this was a very, very nicely detailed lecture, Dr. Anjali. I'm so glad. Meeta, आवाज बंद करो. I'm so glad that you brought the topic of macroprolactinemia inside You told us how to test it. It is very important that all prolactin estimation should include the estimation of macroprolactinemia, because I see levels of 30 and 35, and women are receiving cabergoline endlessly with regular cycles, no symptoms of galacturia. So this is one very important point I would want to again highlight what you told everyone. And I have one question for you, and that is, if a woman has absolutely normal prolactin levels, she has galacturia, which is bothersome to her, and there is no other evidence which could lead to galacturia, like a scar or a injury or renal function is normal. How would you treat this type of a galacturia, which is not associated with hyperprolactinemia, not with lactation, not with pregnancy?
Okay. So sometimes we do see, we term these conditions as idiopathic hyperprolactinemia,
Okay.
or maybe just you're asking about patients with galacturia, but no normal
No
prolactin.
hyperprolactinemia, and it is
Yeah,
very
but we have,
bothersome for
yeah,
us. She wants to stop this
yeah.
galacturia.
So I think in that case, giving a short course of cabergoline, maybe just 2
Correct.
tablets of cabergoline may just stop the galacturia, and
Uh-huh.
we can tell her to, stop wearing tight garments or stimulating the nipple area, or there are, avoiding medications which are known to cause galacturia can be offered to them.
Thank you so
Otherwise,
much for this answer. Thank you so much. Because I had asked this question in an international forum, and the answer was lower her prolactin levels, even if they are normal, because probably the breast threshold for galacturia has gone down for her due to various reasons, like you've described. So I'm so glad to have heard your lecture. I've learned a lot of things, clarified a lot of insights into it, and the forum is open to all the delegates to ask questions.
So I'll just ask the questions which are listed in the chats box, Satya. One is like, what is the minimum limit of prolactin level where you would start cabergoline? At what value?
So as I mentioned earlier, not all high prolactin need to be symptomatic. So we treat symptomatic hyperprolactinemia.
Okay, so
Asymptomatic hyperprolactinemia, we have to look for causes, what could have caused the high prolactin. So as I
you don't
mentioned earlier,
treat the number. Don't treat
yeah,
the
we
number.
don't look at the number, yes.
Number, right.
But any value which is say about 200
Okay.
is considered tumoral cause as unless proven otherwise. But there are certain medications which can elevate the prolactin to about 200. So any value above 200, we should definitely think of prolactinoma or a cellular mass. Even non-functioning tumors can cause stalk effect. But values above 100, between 100 to 200 can again be due to a non-functioning cellular mass. So there we have to look at it more seriously. So if you have a very borderline elevated value like 30 to 40, you could actually ask the patient about the sample collection. We can repeat it again. But if they are asymptomatic, regular cycles, I think there is no indication to treat.
Right.
Look
So
for
even
macroprolactin in
so
those
even if
patients.
someone doesn't have headache, we would go to 200 as a cutoff to do the MRI.
Yes, 200, even above 100, sometimes we do ask for MRI because we ask for other questions. Patients may have headaches with 100 because this could be a non-functioning pituitary tumor where the prolactin is elevated because of the stalk compression.
All right.
So prolactin may not be high, but it may be only moderately elevated to 100 to 150.
And
So
after
even there, so it all depends on a clinician's suspicion. So we have
that's
to
a
take
very beautiful point. You just work on the clinical picture, not just go by the lab report alone. I think that's a seriously important take-home message. And with respect to how many weeks you would put them on treatment before you check for prolactin level again.
Yeah, so if it is a tumoral cause, generally we start with 0.5 milligram of cabergoline twice a week, and the medicine is given along with dinner. It can cause some amount of postural giddiness. That's why we start with the dinner. So always is better given along with dinner and can cause some nasal congestion. So normally we estimate the first prolactin after 4 to 6 weeks. So 6 weeks later, we can see the values are come down, then we start coming down on the dosage. Now, patients with prolactinoma, usually the treatment is long drawn. We must tell the patients that even if the prolactin comes down, they should remain on minimum dose of cabergoline to maintain the prolactin in the normal range. It may actually sometimes take years. And if a woman conceives on treatment, if it is a microprolactinoma, we stop the cabergoline after she conceives. But if it's a macroprolactinoma, there is a higher chance that these tumors may enlarge during pregnancy. And in those patients, we continue with cabergoline. We do not use bromocriptine these days unless patients have cabergoline resistance document.
So is there a cutoff level for macroprolactin? That's another question.
It's not for macroprolactin, you're saying,
Yes.
or macroprolactinoma?
Prolactin. I mean, that's a
No.
question. Okay,
No. Macroprolactin can be a varied number. So it can be anywhere between, usually it will not cross 100. What we normally see in clinical practice is macroprolactin is between 40 to 70 nanogram per ml.
Right. Is there a condition called transient hyperprolactinemia? And if so, how do we verify it?
Yeah, that is what is I mentioned, drug-induced hyperprolactinemia. It's very transient. You stop the drug, the prolactin just crashes within a week's time. So we normally re-estimate the prolactin within 2 weeks, document a normal value, reassure the patient and send them back. And probably we also write a note in their case file that please do not prescribe prokinetics for this agent, or we tell the patients to tell the doctors.
Right, so that's great. I think we've gone through so much as to what the level is, when to test, what is transient, what is macroprolactin, and the importance of MRI, and how even sexual dysfunction is an important question to be addressed along with hypogonadism. Thanks for the insights, Dr. Anjali, and it was great having you here. And with this, can we move over to the next topic if we don't have any more questions? I think I've taken most of the questions and she has covered a lot of the questions as well, right? So we move on to the next topic of this evening. Can you play me the CV of Dr. Jayashree Gopal? Dr. Jayashree Gopal is a great friend of mine and my husband as well. And she's an American board certified internal medicine, endocrinology, diabetes, and she had finished her MBBS at Madras Medical College. She's the director of Diab Endo India, founder and trustee of Diab India Foundation, a senior consultant at the Apollo Group of Hospitals, vice president, Endocrine Society of Tamil Nadu and Puducherry. And it's a pleasure always listening to Jayashree Gopal. And we have an interesting topic, thyroid. That's a hormone day in and day out, which fertility clinicians end up testing. And again, we read through your topic, I'm sure we'll all get the same insight, when to test, what level, how to understand thyroid's influence on the rest of the fertility hormones. Dr. Jayashree, I request you to share your screen and we're eagerly awaiting for your presentation.
Thank you very much, Rajapriya. It's indeed a pleasure to be here and always a pleasure to listen to Anjali talk. I learned a lot also. So thanks, Anjali, for that. Yeah, I hope you can see my...
Yes, it's visible.
Yeah. So my topic is structured a bit differently. I'm just going to present a series of cases. These are all, the real life clinical scenarios that we encounter and the problems we face. I think all of us are familiar enough with the thyroid. I just wanted to talk about the challenges that we face sometimes clinically. How do we interpret reports and how do we implement thyroid control? So this is one of the first very common things. 27-year-old lady married for 6 months and unable to conceive. And periods are regular. TSH is borderline elevated. Here you can see the normal range for TSH in that lab. And that's one of the first things we need to do. We need to go back and look at the normal range for the TSH. If you look at a lot of the guidelines, they give standard cutoffs of TSH. They say a TSH of about 4 or whatever it is. I'm not getting into that controversy, but it's important to go back and look at the lab because each lab also, it keeps varying. I'm pretty sure it's the same because a lot of these labs are, nationwide based and their normal ranges change. So it is important to go back and look at the range, but we'll presume that it was slightly above the upper limit of normal. And the free T4 was well within the range and all other hormones are normal. So do we need to treat? Of course, I'm talking to an audience where you know that we need to treat, but let us assume that she's not planning pregnancy. What do we do in a situation like this where the TSH is borderline elevated? This is the definition of subclinical hypothyroidism. I actually personally do not like the term subclinical hypothyroidism. I prefer to call it a biochemical hypothyroidism or a biochemical elevation in the TSH. But technically, it is defined as a TSH value, which is above the upper limit of normal and below 10 with a normal free T4. So it's more of a biochemical diagnosis, but we give a clinical slant to it by calling it subclinical hypothyroidism, which is somewhat of a misnomer. Most important thing, again, like Anjali said, a very detailed history. And if there is any chance of pregnancy or planning pregnancy in the next 1 year, of course, in our country, no one is planning a pregnancy. They all become pregnant. So mainly, I think we all need to ask, is there any chance that you're going to be able to conceive? If it is, then I would say just go ahead and get started on thyroid tablet in a situation like this. But let's say this lady is not planning a pregnancy and she's using adequate, contraception, or she's not planning a pregnancy, then the other things that we would need to look at are, what is her blood pressure? Does she have a swelling? Does she have any pedal edema, ankle swelling? The examination of deep tendon reflexes is something that we all learn in medical college. It is sort of an outdated test. It is still useful when people have very severe gross hypothyroidism. Let's say you're seeing somebody with a TSH of 150, like the one that Anjali presented, with a very low free T4. In that situation, maybe checking a deep tendon reflex is helpful. I don't think any of us do it in our clinical practice, but these other things very definitely, I think, are very important for us to decide whether borderline elevations of TSH need to be treated. And in the lab testing, of course, apart from a free T4, which is essential, I would also look at a lipid profile and thyroid antibodies to determine whether or not this profile needs to be treated. So when do we consider starting levothyroxine therapy in a situation like this? Any symptom, anything. So sometimes we can go deep into any hair fall, fatigue, tiredness, body pain, joint pain. Of course, any irregular cycles, so missed periods, more flow than usual, menorrhagia, any change in her cycle history. If there is any chance of pregnancy in the next 1 year, if you feel any swelling of the thyroid gland, or if you get an ultrasound and you find that there are changes either of developing nodules or changes of thyroiditis on the ultrasound, if the blood pressure is high normal, if there is presence of other physical changes like ankle edema, if there are positive antibodies, particularly a high titer of anti-TPO antibody, but either one, even if a thyroglobulin is high but TPO is normal, or vice versa, I would still go ahead and consider treatment. If they have a high, particularly LDL cholesterol, or if there is a very strong family history, maybe. So if she says, like, say, her mother, her grandmother, her maternal aunt, everybody has got a thyroid problem, then again, maybe she is on her way to developing a underactive thyroid or hypothyroidism, and we can consider treatment. When can we just monitor in a situation like this? Again, these are all the criteria that I would say we need to look at or need to tick off. A person who's got a borderline elevation of TSH with no symptoms, with normal cycles, not planning a pregnancy, taking adequate precaution against a pregnancy if she is a married woman, negative antibodies. Let's say you do an ultrasound neck, if there's any suspicion of goiter and the ultrasound is normal, normal lipid profile, normal blood pressure, and nothing else on physical exam to suggest that she needs to be treated. So borderline elevations of TSH, we do need to take seriously. We need to look at all of these parameters. At a minimum, definitely check their lipid profile and thyroid antibody, particularly if you're not choosing to treat. Because quite often we get women who come in who get these tests done as part of, their nutritionist has asked them to do it, or somebody else has asked them to do it. And do we really need to treat it or not? This is sort of a checklist that we go through. This is the American Thyroid Association recommendation, very similar to what I said. Treat definitely if the TSH value is more than 10. Treat definitely if they are symptomatic. So let's say even if you have a TSH of 6 or 7, but they're having some sort of tiredness, fatigue, you can certainly give a trial of thyroid tablets to see how they feel. If they have a high risk of progression to overt hypothyroidism, again, strong family history, high level of or a high titer of thyroid antibodies, any chance of pregnancy, or if they're approaching you because they're worried about infertility. When do we not treat? If the TSH is 5 to 10, along with negative antibodies, no goiter, completely asymptomatic, no thyroid pathology by ultrasound, not planning a pregnancy, no history of infertility. Even in this situation, if the TSH is borderline, what they recommend is to follow up the thyroid function every 3 to 6 months. And if it's been stable, if it's remaining at, say, the 5 or 6 mark all through, maybe we can increase the frequency to once in a year. Treatment, the treatment is, it still remains levothyroxine. And the adult recommended dose is 1.6 to 1.7 microgram per kg per day. Now, while this is recommended as a guideline, most often we start depending upon the actual TSH value. So borderline elevations of TSH, most of us would begin with 25 or 50 micrograms and then slowly increase it depending on what the dose responses. Some people respond well even to minimal doses. Some people require a much higher dose to achieve euthyroid status. And also this is important to remember that younger ages actually require a higher dose per kilogram. So at birth, for example, they will require almost 10 times a higher dose per kilogram. As we get older, we require a lower dose per kilogram. So that lady, we need to consider whether she is, of course, she approached us because she was having difficulty conceiving. So a lady like that, definitely we would treat, but for a specific reason like that. Another sort of common clinical scenario that we come across, not uncommonly, and which we need to keep in mind. This is a 34-year-old lady with a history of hypothyroidism for 10 years, trying for her second pregnancy. She also has a history of seizure disorder and she's on anti-seizure medications. This is a current thyroxine dosage. She's on levothyroxine 100 for 5 days and 125 for 2 days. And I just want you to focus on, first of all, the TSH values. So initially, when I had seen her in June 2017, her TSH was 0.02 with a fairly normal free T4, nearer the lower limit of normal. And this was her dosage, but she had a seizure 1 week prior to presentation. We made some adjustment of the thyroid dosage. I made it 75 on all days. And then when I saw her 3 months later, her TSH had come to 1.2. 3 months later, again, her TSH, when we saw her, had jumped to 10. Her free T4 had dropped slightly below the lower limit of normal on the same dose. Again, she said that she'd had a seizure 1 week earlier. And this is when the husband actually made an observation saying that he had also noted that every time there was some fluctuation of the thyroid, it seemed that there was a seizure. And I'll come to that in a minute. Thereafter, we made some further adjustment. We did some, sort of tuning of the thyroid dosages. This is what endocrinologists like to do. And thereafter, she remained somewhat stable. The TSH values remained between 1 to 1.7, and the free T4, though it would always go nearer the lower limit of normal, it remained within the range for the most part, and she remained seizure-free for 2 years at that time. And now for the past sort of 5 years, she has remained seizure-free. The important things to understand from this case presentation is that, number one, fluctuations in thyroid levels can and may precipitate seizures. So someone on seizure medications, on thyroid medication, important to check their thyroid maybe every 3 months and make sure that they are maintaining their levels in the normal range. TSH value may be temporarily elevated after a seizure. So it is important when we interpret thyroid values to consider how long it has been since their seizure and whether that is affecting the TSH value. Anti-epileptic medications tend to lower free T4 levels. So that is what was happening in that lady. Quite often we'll find that the values, so free T4 may not be a very good marker of monitoring whether we are giving a proper dosage of the thyroid tablet in this situation. Better to use a TSH for the most part. In fact, for most monitoring and follow-up purposes, most of us would only ask for a TSH, but invariably the lab lands up doing a TSH and a T4 and T3, either total or free T4, but a free T4 level would be affected by the anti-seizure medication. And we need to use caution when we are adjusting doses of levothyroxine in people with seizures and interpreting thyroid levels when they are on anti-epileptic medications. There are other common medications that affect the TSH, particularly metformin. Metformin causes a little bit of a drop in the TSH, a little bit of a drop, meaning it may go from, say, 0.5 to a 0.2, but it does cause a drop in the TSH. This particularly occurs when the TSH is in the upper limit of the normal range or above the normal to begin with. And the experts are not clear whether this is partly related to a little bit of weight reduction that happens with metformin. Is that the reason why the TSH is dropping? Apart from metformin, some other commonly used medications, glucocorticoids, can shut off the TSH production. Contraceptives, we know very clearly, they increase the total T4. So any person who's on a contraceptive pill, remember to look only at the TSH and the free hormone level. So these are the two that we need to be sort of keep in mind, in addition to metformin and anti-epileptics when we are interpreting thyroid levels and thyroid reports. Moving on to the next clinical scenario, this is a 27-year-old lady with hypothyroidism and some impaired glucose tolerance trying for her first pregnancy. She is taking levothyroxine at this dose, 75 for 5 days, 100 for 2 days, and she's also on metformin. And she's also on folic acid and iron, which she's taking in the night. She's very regular with the thyroxine. She gives a 1 to 1.5 hour gap between the thyroxine and food. And this is what had happened. This, in fact, happened during the lockdown period. And you can see it was at the start of the lockdown. This was when initially I had seen her 62.5, her TSH was 5.72. So we adjusted the dosage a little bit. TSH came down nicely because she was trying for a baby. We were trying to get a TSH to less than 2.5. On the same dose again, 3 months later or 2 months later, it jumped up to 6.2. We made a further adjustment of dose. It jumped again to 11. And we were puzzled, and I knew that she was very compliant. Obviously, the first thing we suspect is compliance, but this is a lady who's very keen on conceiving. So I was sure that I believed I took her at her word when she said she was very regular with the medication. She was also very upset about this. But at this time, we were doing online consultations. So one good thing was I asked her to show me the bottle of the levothyroxine, because she kept saying that she was on thyroid tablet. She was sure. Sometimes I get the doses wrong. So I said, just show me the bottle. What had happened was for the, by this time she was on 75 for weekdays and 100 for the weekends. She was using a brand A for the weekday and a brand B, which was a completely different brand, something that we generally do not use for the weekend. When we switched her over to the proper sort of brand of medication, even on the weekends, again, she settled down and her TSH improved. And thereafter, about a year later, she went on to conceive. So this is, again, a very important point to keep in mind, that different brands have different absorptions. So if you're finding that a particular brand is not helping with controlling the thyroid value, consider changing the brand. There are a lot of excipients. Even though the levothyroxine is the same, the excipients that are added are different. So that may alter the absorption pattern for different people. And the other thing about the thyroid, because of that, is in general, we tell people, please do not change the brand. If you're set on a particular brand, whatever it is, brand A, you're taking 100 mcg per day, please don't think the pharmacy will say this is the same as that and give you a brand B, but that will alter the absorption pattern and the pharmacokinetics. So it is important to stick to the same brand for thyroid alone. And in general, it's best to stick to reputed brands and to look at the bottle yourself. Sometimes they make the bottle look very similar to the originator brand. So look at the bottle, make sure it is the brand that you have been used to using. This is another patient of mine. This is Mrs. G, 33. She was also trying to get pregnant, hypothyroid for 13 years. And she came because her TSH had never been under control. It was always 15 to 30. And her thyroid dosage had been progressively increased by her general practitioner. It started with 50 micrograms. She was currently up to 125, but she only weighed like 35 kilos. She only complained of tiredness and fatigue. On detailed questioning, she admitted to the fact that she was very irregular with the levothyroxine because of excessive burning in the stomach after she took the tablet. So some days she'd take it, some days she just felt that it was burning too much, she would leave it. So though she was trying for a baby, because she was having this problem with taking the tablet on an empty stomach, she was irregular with it. So we asked her to take her levothyroxine an hour after breakfast or between lunch and dinner, or nowadays there are studies saying that we can also give it to them at bedtime, provided it's at least 3 hours after dinner. She improved significantly, and in fact, her weight went up to 47 kilos. This sort of gastritis went away, and she did very well. For almost 3 years after that, she took her thyroid tablet about an hour after breakfast. Now she's back to taking it at empty stomach, and now she's able to tolerate it. So for that period when she had that severe gastritis, she could not use it at all for, in the empty stomach in the morning. So we just switched, and she did very well. And she, in fact, even gained weight. Though the main site of absorption of the levothyroxine is the small intestine, the jejunum and ileum, only about 60% of the tablet, 60 to 70% of the tablet is absorbed in a euthyroid state. When they are hypothyroid, even less is absorbed. In hyperthyroid state, more may be absorbed, but in hypothyroid, even less, maybe only 50% of your tablet may be absorbed. And particularly when they are fasted, the absorption is better. But when they are when they take it along with, say, milk or something, or immediately on an empty stomach, the absorption levels do come down. It is influenced by gastric pH. In fact, studies have shown that taking medications like proton pump inhibitors actually inhibit the absorption of the thyroid tablet. So it is associated with increased dosing requirements. Studies have shown that, for example, even taking a PPI the previous night has been shown to affect. The effect of the PPI lasts for 24 hours. So when people are on PPIs, that is one more reason why the thyroid dosage requirement may go up, and it's important to keep it in mind. So taking levothyroxine can cause severe acidity in some people. In those people, we can try giving it at other times of the day. We can give it even, for example, even in the night. Ideal to have at least about an hour, if not more, gap between the thyroid tablet and the food to begin with, so that the body can get adapted, and then slowly try and get them into the empty stomach in the morning. For example, we do this quite commonly in the pregnancy situation, when sometimes when they take it in the morning and they immediately throw up the tablet, we tell them take it at a different time, and once the nausea settles, you can come back to the morning. Other common queries that we commonly encounter are, when do we do the thyroid blood test? TSH can be done at any time, but there is a circadian rhythm. In general, the TSH values are slightly higher in the evening. So when we are looking at values of TSH below 2.5, or when we are looking at borderline values, always best to stick to empty stomach in the morning. Similar to how Anjali was mentioning about the prolactin. It's very sensitive to time of the day. It's very sensitive to food intake. The T4 levels, whether we are looking at free T4 levels or total T4 levels, can be affected by food intake. Therefore, the T4 levels, T3 levels, best to do on an empty stomach before taking the thyroid tablet in the morning. This is another scenario, a 48-year-old lady who presents with complaints of weight gain. This is not a pregnancy situation, but I just wanted to point this out for a particular reason. She's not planning a pregnancy. At the age of 48, her periods have started becoming irregular. Examination is normal. Year before presentation, this was her weight, 65. Her TSH was 3.2, free T4 was 1.2. About a year later, she'd gained about 7 kgs. Her TSH was 6.5. We, of course, repeated it. It was 7.2. Antibodies are negative. She had no goiter. Lipid profile was normal. Now, this is a situation where the weight gain, probably because of the perimenopausal period, the weight gain, and this can happen at any age, though I presented a 48-year-old lady, this weight gain that happens probably because of the perimenopausal period in this lady has caused the TSH to go up. If she has no other symptoms, we do not need to give a levothyroxine just for the fact that she gained weight. If we encourage her to lose weight with, say, diet and exercise, we can always wait for 2-3 months. There's no pressing urgency in a situation like this to get started on thyroid tablet. In fact, quite often what you will notice in your clinical practice is some people complain that they gain weight after they start taking thyroid tablet. So in a situation like this, better to encourage them to lose weight. If they have no other reason to get started on thyroid tablet, lipids are normal, no goiter, no nodule, no chance of pregnancy, we can certainly wait. Encourage her to lose weight, repeat the test. Once she loses weight, repeat the thyroid and see. And after she loses weight, a repeat TSH was 3. So this is again an important thing to keep in mind, that weight gain can increase the TSH, maybe because of the effect of leptin, which is made by the adipose tissue. Weight loss can reset the TSH. So like I said, if no pressing need to treat the elevated TSH, you can recheck after weight reduction. And unlikely for a TSH value to present with weight gain alone, whatever be the level of the TSH, usually they'll have some other symptom along with it. And I'll finish up with this case, very, necessary for people undergoing fertility treatment and their thing. Very common scenario, 35-year-old lady, hypothyroidism, positive thyroid antibodies, on levothyroxine for 10 years, undergoing fertility treatment. So this was a values on Jan 2019. This was a TSH 100. That time they were planning an ovulation induction. So the dosage was increased to 125. When the test was repeated again in September, this was 3 days after ovulation induction. After several cycles of ovulation induction, a TSH was still at 4.5. But this test was done 3 days after the ovulation stimulation. The dose was increased to 150. 4 months after that, when she came, her TSH had dropped to, she became over-replaced. Her TSH had dropped to 0.04. The ovulation induction was unsuccessful. Dosage was reduced back to 100. And this was when actually she came in to see me. So I said, just stay on the 100 for a while. It's been changing a lot. We'll just wait. A month later, she was stable and she was just asked to continue on the 100. Of course, we know that ovulation induction, because of the effect of estrogen, increases TSH and the total T4 levels. This increase in the TSH is more pronounced if they have baseline thyroid autoimmunity. So if they already have positive titer of thyroid antibodies, remember that they're going to have a bigger, and if they're on levothyroxine therapy, more likely for the TSH spike to occur. The peak TSH rise occurs 3 to 5 days after ovulation induction. This rise in the TSH settles by 10 to 14 days in most, but it may persist up to 3 months according to a few studies. But in most people, it settles down after 2 weeks. So prior to ovulation induction, if any TSH is above 4, go ahead and treat. Get them started on levothyroxine. It does not matter if antibodies are positive. It does not matter what their free T4 is. It is in this borderline gray zone. If the TSH is below 2.5, that's fine. If the TSH is between 2.5 to 4, antibodies are positive or negative, I think you have to take it in a case-by-case scenario. You decide based on other factors, particularly when antibodies are positive, you decide if this particular case merits levothyroxine replacement or not. I would tend to monitor. If the TSH starts going above 4, I may treat. If not, I may not. After ovulation induction, check a TSH after 2 weeks. And of course, if they're on treatment already, aim to keep the TSH below 2.5. And I went through this. If they have positive thyroid antibodies, only start levothyroxine if the TSH is above 4. Borderline TSH values, go on a case-by-case basis. And once they're on that ovulation induction protocol, try to check their thyroid values exactly 2 weeks after your induction, like 5 days after the ovulation induction is completed, 2 weeks from that. So try to schedule the blood test at that time, maybe every couple of months or so, to monitor their thyroid levels. So I'm going to stop there actually, and and just to finish up and say that I hope that you found these real-life clinical scenarios useful. And if there are any questions, I'll be happy to answer. The art of thyroid is really in the finer nuances and trying to maintain the levels within the accepted ranges.
Thank you so much, Dr. Jayashree Gopal. I think thyroid is a never-ending subject. No, you really have to go on and view it from different angles. Abba, ma'am? Abba, ma'am? While I would just see if Abba.
Yeah.
Abba, your
Yeah.
comments, ma'am?
I think both the lectures were brilliant lectures, and they were by people who were really treating these hormonal dysfunctions themselves. And I feel that we don't need to stick so much to 2.5 to 4 as was told to us, that you can just let go, observe, even if she's pregnant or she's attempting pregnancy, antibodies present or not. 2.5 to 4 is the gray zone, and it is better not to jump onto treating. Suppose it's 3, we can just leave her alone rather than adding on a medicine. This is a good take home message. One thing I learned from today's talk was TSH can be done at any time of the day, whether full stomach or not, but T4 is to be done best empty stomach. Thank you very much for such a lovely lecture.
Thank
and
you.
both the lectures were brilliant lectures.
Thank you, ma'am. And I think Dr. Jayashree, you made a good point, no? Sticking to the right brand, and like iron, no?
Yes.
Iron molecules suit certain women. We have to be careful about the brand which suits the woman.
Dr. Jayashree, which brand do you prefer is the best?
Generally, there are 3 brands that I use, which
Mm-hmm.
are the old brands.
Yeah.
So the Abbott one, the GSK one, which is Eltroxin, the Thyronorm, and the McLeod one, which is Thyrox. Those are the old
and Thyronorm.
Yeah, those are the old and trusted brands.
Okay. Thank you for all the information. Brand is a very new thing which I heard. The T4 to be done on empty stomach is again something which I learned from your lecture. And I think all of us must have taken some or the other take-home message from both the lectures.
At what point, Dr. Jayashree, you will say this person is having an autoimmune thyroid dysfunction? Just if the thyroid antibodies are high, would you go by that?
So autoimmune thyroid disease is sort of diagnosed in different situations. Sometimes it's it's always a combination of thyroid antibodies, either thyroid antibodies with a goiter, or thyroid antibodies with nodules, or thyroid antibodies with fluctuation, either hypothyroidism or hyperthyroidism. So some combination of the positive thyroid antibodies with some other situation. Again, I personally think it's an overused term. I don't like endocrinologists, I think, are the doctors who use thyroid antibodies the least.
Okay.
We tend to make our decision, and I'm sure, I don't know if Anjali is here, I'm sure she'll also agree, because our decision to whether or not to do anything about the antibodies, it's a genetic inherent tendency to make those antibodies. So, and sometimes people just get so hung up, they get values of 800,000 and they get very worried about it. There's absolutely no need to worry about the actual titer or the levels. Actually, labs only have to give us the report as positive or negative.
All right. And so do you think thyroid antibody testing should be a part of our testing of thyroid hormones? If we think it is an infertile patient, it is good to correlate that as part of the test.
I would only recommend doing it if you're having a borderline TSH that you don't know whether you're going to treat or not.
Right. So if you're caught between anywhere from 4 to 8 number or something.
Yeah, some 4, 5, something, and you're trying to decide. Even then, I would rather just repeat a TSH in a few weeks and then make the decision.
Fine. So any very low value, we would just name it as biochemical, like how you say, and then
biochemical hypothyroidism.
Right. And it is better not to start with that 1.6, 1.7 milligram. It's better to start with the low dose, say 25 mics or something, and move forward.
Yes, absolutely.
And how many weeks later would you want the test to be repeated?
So somewhere between 4 to 6 weeks. It depends on sort of, what is the situation. So if it's an early pregnancy and I'm looking at getting the thyroid levels normal, I would do it in 4 weeks. If someone is, anxious to conceive, maybe. But ideal is about 6 weeks. The earliest you can do it, it takes some time for the half-life to settle. So 6 weeks is ideal.
And a good lot of women, right? They put weight and thyroid hormone together. Like I became heavy, I have thyroid problem. It is like you have to accept.
It's just the reverse, I think. It is just the reverse.
So how do we talk to them? Like dyslipidemia is something we have to work up and ensure that that is also separately treated if they are obese.
So dyslipidemia may be occurring because of the hypothyroidism. So let's say you have 2 lipid profiles, one last year, one this year, and this is suddenly shot up. You don't need to rush into necessarily putting them on statins unless your LDL is above, say, 190 or something, which anyway requires a statin. Once you treat the thyroid, once you treat the hypothyroidism, the TSH values will settle.
I have a question. In postpartum patients, when should we do a TSH level if they were on a thyroid replacement during pregnancy?
It's usually recommended 6 to 8 weeks after delivery. By then, the TBG changes related to the pregnancy settle down, and the thyroid requirement also tends to come back. In general, we reduce the dosage anyway. What I say is from the day after delivery, reduce it back either to your pre-pregnancy or at least by 3/4. So if they're on 100, I'll say go back to 75 or something. The guidelines say ask them to reduce the dose after 2 weeks. But, people may not remember, at least a day after delivery, that they remember better. So from the day after delivery, just reduce the dose, check it after 6 weeks or 8 weeks and let us know.
Thank you.
There's someone with a question, why is it for the weekdays there's one dose and why for the weekend there's another dose?
Yeah, I know. That's my personal quirk.
Right.
I think
the other person asked a question. There is a weekly once dose formulation available for thyroid hormone?
No.
Yeah.
But there are no, it's not available. But there are case reports where, where you're suspecting compliance, like the directly observed anti-TB therapy. They have given like 700 micrograms at one go. They get people into the clinic and ask them to take the 7 tablets at one go, like that.
Right.
But in general, we don't do it. So to answer also that previous question, why are you having one dose for the weekends and one dose for the weekdays? We tend to think of a per weekly dose.
All right.
So what is their total dose per week? And then we can try to manipulate that rather than trying to manipulate their daily dose. Sometimes we have to do these little things to manipulate their weekly dose.
Okay. I guess it answers. That's why the once a week dose is also there for non-compliant patients. I think you have taken most of the questions, Dr. Jayashree, and it's going to be 6:30 as well. It was fabulous listening to you.
Thank you.
I think both of you have opened up newer insights that every year we have to refine our practice, not just go by numbers, but look at the holistic clinical picture and are they symptomatic? And when we initiate treatment, we have to be responsible in tracking and understanding whether it's transient or not. So it's important history taking and clinical examination. And thanks to Dr. Anjali Satya and Dr. Jayashree Gopal again. It's been great. And thanks for Abba ma'am for putting in her expert comments. And with this, we come to the end of the webinar of the evening on fertility hormones and the interplay with fertility treatment. So thank you so much.
Thank
Bye,
you.
ma'am.
Thank you,
Bye-bye.
Rajapriya, for having me over for this seminar. It was a very nice learning opportunity for me too.
So thanks to both the teachers of the day. And with this, signing off, good evening and have a great weekend.
Thank you.
Yeah.
Bye.
Bye.
Wonderful.
Thanks to Karan as well for giving us this platform to organize the webinar on behalf of IFS.
Welcome.
Yeah. Thanks, Karan. Bye.